everyone. My name is Sandra, and I'm with my co-interpreter, Andrea. We will be providing Spanish interpretation. And as it was mentioned, there will also be American Sign Language interpretation offered by our partners at HeartSong. So we're going to give some instructions to access the interpretation on Zoom. We can go to the next slide. Buenos días, mi nombre es Sandra, estoy con mi cointérprete Andrea y vamos a estar participando como intérpretes de español, así que les vamos a decir cómo acceder a la interpretación en Zoom. So on your computer, you will find a globe icon at the bottom of your screen. If it's not there, it's in the three-dotted menu that says more. Click the globe icon, go to language interpretation, and choose English. With this, the feature will be activated. Remember to not mute original audio so you can hear the main room. Entonces, si están en su computadora, vayan al icono de globo terráqueo, encontrarán la opción interpretación de idiomas. Si no está ahí, está en el menú de 3 puntos que dice más. Vayan a la opción de idioma español y con esto quedará activa la característica. Recuerden que pueden silenciar el audio original si solo desean escuchar la voz de las intérpretes. Remember to not mute original audio or you won't be able to hear the main room. We can go to the next slide. If you're joining from a mobile device, you can go to the three-dotted menu that says more, and then go to the language interpretation option, press English, and then done. With this, the feature will be activated. Once again, do not mute original audio or you won't be able to hear the main room. Si están en un dispositivo móvil, les invitamos a buscar el menú de 3 puntos que dice More o Más. Ahí vayan a la opción Interpretación de idiomas, elijan español y presionen Activar o Listo. Y con esto tendrán la característica activada. Recuerden que pueden silenciar el audio original si solo desean escuchar la voz de las intérpretes. If you're joining from a Chromebook computer or a phone call, you won't be able to access this feature. Si se unen desde una computadora Chromebook o una llamada telefónica, no tendrán acceso a esta característica. We ask you that if you have any trouble accessing the feature, please leave a message in the chat and we will be happy to assist. Si tienen algún problema accediendo a esta característica, por favor, déjenos un mensaje en el chat y nos dará gusto ayudarles. With this, we'll go back to our hosts. Thank you.
Yes, thank you so much, Sandra, for sharing how to receive the interpretation. Also, if you would like to see the English slides, please look at the top of your Zoom bar. You will see 2 tabs, one that says English slides, and then there will also be one that says Diapositivas en Español. These will allow you to see the language of the slides that you choose. If you have any issues with this, please just message in the chat. It should be open for attendees to ask questions. And Sandra, someone asked in the chat, should they be muting their original audio?
No, please do not mute.
Great, thank you. And we can go to the next slide. As you know, for this session, we will be offering CME and CEUs. At the conclusion of the session today, once you close your browser, an evaluation page will automatically pop up on your computer. We would very much appreciate your feedback on this brief evaluation as it helps us improve the quality of our program. Also note that completing the evaluation will be required in order to register for CME and CEU credit. We are offering continuing medical education credit through the American Academy of Family Physicians for this webinar. Credits are the equivalent of AMA Category 1 CME credits, which are largely accepted as CEU credits as well. Please check with your own licensing body to determine whether these credits are accepted by them. If you would like to claim credit for this time, you will be guided through the appropriate steps once you complete the evaluation. Next slide, please. So you are joined by myself and my colleague Kate from Health Partners on IPV plus Exploitation. We are led by Futures Without Violence and funded by HRSA's Bureau of Primary Healthcare to provide technical assistance to health centers to develop and implement evidence-based strategies, protocols, and partnerships to prevent, identify, and respond to intimate partner violence and human trafficking. We offer webinars such as the one today, communities of practice. We have an archive of our webinars on our webpage, and we also produce clinical patient tools, and we also discuss our evidence-based cues intervention. If you would like to learn more, please visit us at www.healthpartnersipv.org. And as a reminder, slides and recordings for this session will be available after the end. Next slide, please.
Hello, everyone. My name is Ben Sullivan. I use he and him pronouns, and I'm the program coordinator for the National LGBTQIA Plus Health Education Center. We're also joined by my colleague and our program manager, Jack Dalton. The National LGBTQIA Plus Health Education Center is part of the Fenway Institute, the Research, Training, and Health Policy Division of Fenway Health, which is a federally qualified health center in Boston and one of the world's largest LGBTQIA Plus focused health centers. If you haven't already done so, please join our mailing list so you can hear about future webinars, trainings, publications, and resources. And you can sign up for that on our website, which is on the slide. Our mission is to provide educational programs, consulting, and resources to help care organizations optimize their ability to provide accessible, high quality, and cost-efficient care to LGBTQIA plus people. We offer a number of educational opportunities, including training and technical assistance, grand rounds, which are now virtual, and many online learning opportunities. Much of our content is available for free on our website and able to be submitted for CEU and CME credits. Next slide, please.
Today, we will be joined by Dr. Kevin Ard, the Medical Director of the National LGBTQIA Plus Health Education Center at the Fenway Institute, as well as the Director of the Sexual Health Clinic in the Massachusetts General Hospital, as well as Ashley Sly, the Director of Positively Safe and Domestic Violence Counts at the National Network to End Domestic Violence. And we will be starting our presentation off with Dr. Kevin Ard.
Thank you so much. It's great to be here. Good morning and good afternoon to everyone. My name is Kevin Ard, and I'm an infectious disease doctor and the director of a sexual health clinic in Boston. Next slide, please. I'm going to be talking about PrEP, HIV pre-exposure prophylaxis, and I'll be sharing some general information about this intervention and then also talking a bit about how this may relate to intimate partner violence before turning things over to my colleague, Ashley Sly. So first off, what is PrEP? Well, again, PrEP stands for pre-exposure prophylaxis, and it is a patient-controlled strategy to prevent HIV acquisition by the use of antiretroviral medication, which is taken in advance of exposures to HIV. A few comments about this description. PrEP, again, is medicine taken before possible exposures, so this differs from PEP, which you may have heard of, which is post-exposure prophylaxis. And that is when people may take a 28-day course of medication after a discrete exposure to HIV to prevent acquiring HIV. The other thing I would say is that all the medicines that are used for PrEP are antiretrovirals. They're medicines that were first developed to treat HIV, but in this case, we're not using them for HIV treatment. We're using them for HIV prevention. And these medicines in and of themselves are not a complete treatment regimen for HIV. They're just part of one, but they are sufficient to prevent HIV. And in general, PrEP care consists of the use of oral or injectable medication with some associated laboratory testing and other care. Next slide, please. One thing we know is that PrEP use is not commensurate with need, and this is especially true among women. This slide shows something called the PrEP equity ratio, and that is the idea that if you have a group of people and some proportion of them could benefit from PrEP, based on their likelihood of acquiring HIV, and you compare them to another group of people, again, some proportion of them also may benefit from PrEP based on their likelihood for HIV, and then you compare those two groups. If this ratio is 1, it means that in both populations, those who need PrEP are on it at the same rate. But we know that this ratio is less than 1 when comparing women to men, which means that as a society, we're not as good at providing PrEP to women who could benefit as we are to men who could benefit. Now, there are other groups in which PrEP is used as not commensurate with need as well, including people who inject drugs. But this difference in women and men is especially stark. Next slide, please. So who is eligible for PrEP? And I'm going to show you some algorithms from CDC that describe who might benefit from PrEP. But I also want to make the point that anyone who asks for PrEP and does not already have HIV is eligible for it. And there are a few reasons for that. One is that someone may not want to describe to a clinician why they are at risk for HIV. And we know that clinicians are not always good about asking about these things or making people feel comfortable discussing their sexual behavior or their drug use behavior. And so simply asking for PrEP is considered an indication for it. The other reason is that, like many other preventive interventions, people may want to protect themselves in advance of a future exposure. And so we should provide PrEP in that scenario as well. Beyond that, though, what are indications for PrEP? Well, if someone has had anal or vaginal sex in the past 6 months and has a partner with HIV who is not known to be suppressed on their HIV treatment, then PrEP would be indicated. Now, HIV treatment prevents transmission of HIV. You may have heard the phrase U equals U, or undetectable equals untransmittable. That means that people who are consistently virologically suppressed on HIV treatment do not pass HIV on to others through sex. So if someone has a partner with HIV and that partner is consistently on HIV treatment, PrEP likely provides no benefit for that individual unless they have other exposures to HIV, other partners, drug use, etc. People who've had sex in the past 6 months and have one or more partners of unknown HIV status and don't always use condoms would also be eligible for PrEP. And then people who have had a sexually transmitted infection in the past 6 months would also be eligible. And that is because those can be a marker of the possibility that this person may acquire HIV. And this includes gonorrhea, chlamydia, or syphilis for men who have sex with men, or MSM. It also includes gonorrhea or syphilis for women who have sex with men and men who have sex with women. And the reason that chlamydia is not included in that group is that chlamydia is not highly linked to HIV transmission in that population. Next slide, please. Now, of course, people may also have other potential exposures to HIV, such as through injection drug use. And so if someone has injected drugs in the past 6 months and has shared injection equipment, then PrEP would also be indicated. And of course, people may have both sexual and injection drug use related exposures to HIV, so it's important to ask everyone about both sets of exposures. Next slide, please. So what are the current options for PrEP? I'm going to go through each of these and compare and contrast them so you know what's available. The FDA has approved 4 medications for HIV prevention. Next slide, please. And 2 of these are oral options, tablets that people take, and 2 of them are long-acting injectable options. Next slide, please. And here are the names of the drugs. The oldest one that we've had is abbreviated TDF-FTC, or tenofovir disoproxyl fumarate emtricitabine. The next oral option is called TAF-FTC, or tenofovir alafenamide emtricitabine. Our next injectable option is CAB, or cabotegravir. And then the final option, the newest one, is LEN, or lenacapavir. Next slide, please. So these can be taken in different ways. So TDF-FTC is prescribed in general to be taken daily, 1 pill once a day. However, in some populations, there's evidence showing that taking it in a quote-unquote on-demand fashion, or just when needed, can be effective. That strategy means that people would take 2 doses, essentially a double dose, of TDF-FTC between 2 and 24 hours before sex, and then 1 dose daily for 2 days afterwards. And that strategy is considered a reasonable one for men who have sex with men. It's not been studied in the same way in other populations, and so it's not recommended for other groups of people. TAF-FTC is a tablet taken once a day. The cabotegravir injection is given once a month for 2 doses, and then every 2 months thereafter. And lenacapavir is given every 6 months. One of the nice things about these long-acting injectable therapies is that there is a kind of a window period around when the doses are due. So, for example, cabotegravir is not doesn't have to be given exactly every 2 months. There's plus or minus 1 week around that date. And then for lenacapavir, there is plus or minus 2 weeks around the due date. And so essentially someone has a month-long window in which they can get to a clinic to get their subsequent injection. Now, I should mention that all of these drugs have been proven to work in randomized trials to prevent HIV, but as we'll talk about in a couple of slides, the populations in which they have been studied differ a bit. Next slide, please. So TDF-FTC has been shown to work in women, in men, and in people who inject drugs. TAF-FTC, however, has been primarily studied among men, and data are very limited in women. When this drug was approved by the FDA, people who have receptive vaginal sex were excluded from the approval because of a lack of data in that population. We do now have more data, and it looks like when this medication is taken as prescribed, it does prevent HIV in women as well. But the amount of data we have on that topic is relatively small compared to the amount of data we have for some of the other PrEP drugs. Cabotegravir has been shown to be superior to oral PrEP in women, men, and other populations, probably because it obviates the need for daily pill adherence. And then lenacapavir has also been shown to be superior to TDF-FTC for PrEP in women and men and other groups. Next slide, please. What about side effects? Every medicine can have side effects. With TDF-FTC, we're mostly thinking about some GI upset when people start that medicine. The TDF component of that drug can have some kidney and some bone side effects, and so we don't use it in people who have those problems to begin with. TAF-FTC can also cause some GI side effects. It can raise cholesterol a little bit and may increase weight. And then if we shift over to the injectable options, these can have what are called injection site reactions. Those could be pain at the site of the injection. Cabotegravir is an injection given into the muscle, typically into the buttock. And so often the side effect there is pain. Lenacapavir is a subcutaneous injection. It's given into the skin. And so the injection site reactions there are a bit different. People may have a nodule at the site of injection. Usually those can be felt, but they can't be seen. However, in very lean people, they can be seen. And those nodules tend to last for a few months before they fully go away. Lenacapavir can also have some drug-drug interactions. I should also mention that our experience with pregnancy differs among these medications. We have a fair bit of experience using TDF-FTC in pregnancy, and the study of lenacapavir for PrEP that led to its FDA approval allowed women in that study to be pregnant. And they collected information on the pregnancies in that study, and there were no concerns about any adverse effects of lenacapavir on those pregnancies, although the total number of pregnancies was fairly small. Regardless of the PrEP option that a patient takes, some baseline and some follow-up laboratory testing is recommended. And in part, that's to exclude HIV infection because these are not treatments for HIV. They would only be partial therapies for HIV. Next slide, please. Now, PrEP is more than just a medicine, and there are often other services that are provided alongside PrEP that can be extraordinarily helpful. And these include condoms. They can include the use of an antibiotic called doxycycline to prevent bacterial sexually transmitted infections like syphilis and chlamydia and gonorrhea. And I'm happy to talk more about that during the Q&A time if people are interested. It may also include contraception or vaccines that are related to sexual health, like the hepatitis B vaccine and the human papillomavirus vaccine or the Mpox vaccine. It may include substance use disorder treatment, particularly for our patients who may use injection drugs or other drugs, and then behavioral health care. Next slide, please. Now, I want to talk about some myths about PrEP, and then the converse, some truths about PrEP. So I hear these myths sometimes in my clinical practice, and they include that PrEP is only for men who have sex with men or people with a lot of sexual partners, that PrEP can have a lot of side effects, that if you start PrEP, you have to stay on it forever, or that PrEP is too expensive and can't be accessed by most people. Next slide, please. So here, I would say, are the truths that counter those various myths. So PrEP is really for anyone who has a high likelihood of acquiring HIV. It is for women. It is for men who have sex with women. It's for people who are not sexually active but may inject drugs and may share injection equipment. It's for people who have one sex partner, but that sex partner has HIV and is not consistently suppressed on their antiviral treatment. And so really, it's not just for MSM or for people who have multiple sex partners. PrEP is also safe and well tolerated. At least one drug for PrEP has been approved for use in the US for more than 10 years. We have a lot of experience using these medicines, and in fact, even prior to their use for PrEP, we have experience using them for the treatment of HIV. And in general, serious side effects are quite rare, and people are able to tolerate them well. And of course, because we now have 4 options, we're often able to find an option that people can tolerate if they have side effects to one of the PrEP medicines. This next point kind of counters the idea that if you start PrEP, you have to be on it forever. PrEP can and often should be started and stopped depending on the likelihood for HIV, which is not constant across the course of someone's life. Sometimes we say that PrEP is used for a season of risk, and if that season passes, then PrEP can be stopped, and of course it can be restarted if there's another season of risk. Now, ideally, the starting and stopping is done with the assistance of a medical provider because some testing and counseling is needed with the starts and the stops, but people do not necessarily need to take it forever. And I would say that it is generally possible to find a PrEP option that is affordable for a patient. There is a generic version of one of these medicines available. There are PrEP drug assistance programs from manufacturers or often from local or state governments. And so it is rare, actually, that we're unable to find a PrEP option for a patient. And I see there's a question in the chat. Will you please expand further on the efficacy of doxypep for gonorrhea prevention, given that GC is treated with a different class of antibiotics? And I'm happy to say a little bit more about that. So first off, doxypep, and if we go back, I think 2 slides, we can look at where I mentioned that. So doxycycline prophylaxis, or doxypep, refers to taking a single dose of doxycycline, 200 milligrams, within 72 hours after condomless sex to prevent the acquisition of bacterial sexually transmitted infections. Now, in randomized trials, this has been shown to prevent syphilis and chlamydia, and in many cases, gonorrhea. As the person asking the question indicated, the impact on gonorrhea is not as robust as on syphilis and chlamydia, and that is because there is some baseline resistance to doxycycline in gonorrhea. However, in the large randomized trial that was done in the US, which showed that this intervention works in this setting, there was a significant reduction in gonorrhea, probably because at the time the study was done, enough gonorrhea was still sensitive to be prevented by this single dose of doxycycline. Now, doxycycline resistance in gonorrhea appears to be increasing, and so it's certainly possible that over time we will not be seeing a benefit on gonorrhea anymore, although we continue to see benefits on syphilis and chlamydia. I'd also say that the impact on gonorrhea seems to be anatomic site specific. So doxypep seems to be better at preventing genital gonorrhea or rectal gonorrhea, and less good at preventing gonorrhea of the throat. So now we can go forward 2 slides, and then 1 more slide. Okay. So what are some considerations for PrEP in the setting of intimate partner violence? And you may have already been thinking about this as I've talked about the features of these medications. First off, I think in some scenarios, PrEP is a great option for HIV prevention because it does not require the knowledge of another person to use it. It's not like a condom in that way, for example. But I think some things to consider would be long-acting injectable options. And this is because people then do not have to have a bottle of pills in their possession, which could, of course, be discovered by another person. They simply would need to be able to go to a clinical site periodically for these injections. And as I mentioned now, we have an every 6-month injection with a 1-month window period around that due date for the dose, which might be an option in some scenarios. I think for all people, it's important that we're flexible about the timing and the format of follow-up appointments. Again, with these injectables, we have a window in which a patient can kind of get in for their visit. And for the newest option, that's 1 month. And also, for people on oral PrEP, having a video visit or a telephone visit is often quite reasonable because they don't otherwise necessarily need to come to a clinical site. Although laboratory tests are due periodically, these can be done at a lab site or done at the patient's convenience. So I think we should try to make PrEP easy. This is preventive care. We need to make it fit into our patients' and our clients' lives. And from my perspective, don't need to be dogmatic about the timing or the format of follow-up appointments. That also feeds into this next point, which is that historically, we've monitored folks on oral PrEP every 3 months with laboratory tests done every 3 months. We're often now spacing that out to every 6 months. But if there is some delay in the laboratory tests, as long as we're able to reach the patient and they remain engaged in care, I don't think that we should stop PrEP due to a lack of laboratory tests on this every 3-month schedule. I think the most important thing is to continue the HIV prevention and then get the labs when you can. Now, of course, this can't go on forever. People do need labs at some point to ensure safety and to ensure that they remain free of HIV. But I think providing some freedom and some wiggle room here is very important. I think for all patients, it's crucial that we address barriers to PrEP persistence, meaning people's ability to stay on PrEP if they want to stay on it. And these can be logistical, and we've just mentioned some of those things. They can be financial. People may lose a job or change jobs. They may lose insurance or change insurance. And that often requires benefits navigation. And so having access to someone who can assist with that navigation is crucial. And then, as with all care, I think it's important to confirm how patients want to be contacted about their PrEP. Do they want to be contacted by text? Do they want phone calls? If so, is it okay to leave messages? Do they want to be contacted through a patient portal? We can now go to the next slide. And I'm going to turn things over to my colleague, and I'm happy to answer any questions later on in our time. Thank you.
Ashley, I think you're on mute. We can't hear you.
Of course I am.
You sound good.
That's just how it always goes. I'm at a conference right now, so it's been a busy couple of days here. But yes, thank you again, Dr. Ard, for really setting the stage for this conversation. I'm happy we're having this discussion and just kind of reflecting back over the years of talking about prevention and where we started. We started talking about prevention as like the ABCs of prevention, of abstinence and being faithful and consistent condom usage. And when we think about survivors, how difficult those things are, of not being able to negotiate condoms, of not having control over your partner being faithful, and not being able to abstain, with your partner. So I think PrEP is such an important tool for survivors and the autonomy that comes with it. So, yeah, let's jump right into it. So, in terms of safety planning, a safety plan is a personalized and practical plan that's designed to improve safety while someone is experiencing abuse, preparing to leave, or after leaving. So, maximizing safety and minimizing potential harm. But even like more broadly, it can also include ways of coping and sources of support, like even who can children go to in a time of crisis. It is developed by a survivor in collaboration with an advocate. So each victim survivor is the expert in their own life, right? They know what has kept them safe. So advocates really help as a guide almost. So thinking about maybe things that a survivor hadn't considered. So maybe they hadn't thought about safety at their job. So an advocate could possibly consider suggesting that and talk them through those potential actions. But ultimately, throughout the process, the survivor is the one who's leading the conversation. So safety plan generally, it could include if someone's fleeing, where they're going to go, or maybe where specifically their children need to go if something happens. Important phone numbers, what they need in their go bag, so copies of documents, medications, who's able to pick up children from school, things like that. But again, the survivor is really driving that conversation. But importantly, it is a living plan. It's constantly evolving based on the survivor's needs and concerns at really any given time. So we don't just set a safety plan and call it done. As advocates, we're checking in with the survivor, seeing how things are going, how can we continue to support them, if there is anything we need to really discuss or change throughout it, anything they really need support with. And then there is this idea of batterer or abuser generated risks versus life generated risks. So these batterer or abuser generated risks, these are created by the abusive partner to maintain power and control. So it could be a broken leg, so it's more difficult for the survivor to get around. So they become reliant on their abusive partner. It could be forcing them to commit crimes so that they have charges on their record. It could be ruining their credit and taking their money. so that they are economically trapped and dependent on their partner for any financial means. And then there's life generated. And these are sometimes called like environmental or even social risks. So these are like ongoing challenges that are faced by survivors separate from the domestic violence. I will say that abusive partners are often known to manipulate these. So these could be mental health challenges, lack of affordable housing, lack of childcare, lack of public transportation, all the things that are just happening in the world that are impacting so many of us. So it could be, thinking about what this looks like in practice, that a survivor has maybe very little work history, making it difficult to find a job. When they find a job, the abusive partner knows that they're lacking those financial resources and skills to find another job. So they begin to sabotage the employment. So the survivor loses their job. So again, becoming reliant on the abusive partner. There's also what's called intervention-related risk, which could be where like a survivor does not receive timely notifications of their partner being released from jail, or timing of referrals to advocacy or other supportive services are taking too long. So being conscious of those kind of risks and how they are impacting survivors. And the safety plans need to account for basic needs that support their social and emotional well-being. So everything from connections with family and friends to mental health care. All in all, safety plans, they may seem like a simple document or concept, but they're rather complex given the individualized nature of each and the harm and barriers that each survivor is really encountering and navigating. Next slide. So specifically when it comes to safety planning around HIV, so these can apply to PrEP, but even more broadly to HIV care. So some things to consider: medication storage. So if someone has a 90-day supply, considering splitting that supply into more than one bottle in case one is tampered with or disposed of, or if they need to flee and they have maybe 30 days of their supply in a go bag, they have it guaranteed ready. They could consider storing their PrEP in a vitamin bottle if they decide to go the oral route. Some people do not want to go with the injectable, and that's their decision, right? We have autonomy over our bodies when it comes to these medical cares, and that's what we promote. So that is an option for some. I worked with a survivor, and she kept hers in a vitamin bottle, and her partner never questioned it. She just always took a daily vitamin, and that worked well for her. Pharmacies, considering possibly switching pharmacies after fleeing, especially if the abusive partner has previously picked up medications for the survivor. If possible, discussing like having a note added to the survivor's like file about who's authorized to pick up their medication, requiring an ID for all pickups at the pharmacy if possible. Those things can be really helpful as well. And then thinking about transportation to and from appointments. So ensuring that transportation respects confidentiality. So if they're coming, say, from a DV program in a shared ride, who's being dropped off or picked up first, to respect that maybe the survivor does not want to disclose their status if they're living with HIV to everyone else in the program. And then medical insurance, thinking about one who has access to the plan, who's the plan holder, and can they cancel the plan at any time without any repercussions to themselves, and then who has access to those explanation of benefits, and then really helping survivors understand what is covered under their plan and what are those limits that are in place. And telemedicine, really considering telemedicine as an option for accessing medical providers. In some communities, there might be very limited options. So this can be a really good possibility for being able to reach more folks, especially, PrEP access via telemedicine has really grown. And being that it comes directly to your door is really helpful for folks, especially if there's limited transportation options. But consider, how are they accessing the appointments and who has access to the devices if they are using telemedicine, when they're meeting, and is that space private when they're conducting the meeting? And then it's just important, I think, to consider more broadly the questions that are raised regarding technology safety. So NNEDV's Safety Net team has a lot more information at techsafety.org if you're interested in learning more about that. Next slide. So specifically talking about PrEP as a tool for safety, right? Survivors encounter a broad spectrum of experiences, such as reproductive coercion. They may be unable to negotiate condom usage or other sexual practices. The abusive partner, they may have multiple partners. They may be forced to, the survivor may be forced to engage in sex with other partners as well. So PrEP is really a tool to empower survivors. It gives them back that control. And survivors have options now, right? That Dr. R talked about. There's 4 options. So it's crucial that survivors are fully informed when they are making decisions. For domestic violence advocates, for those that are joining as DV advocates, right, doesn't require becoming a PrEP expert. Rather, relying on HIV programs and other medical professionals with this extensive experience, but still having those having a fundamental understanding of what PrEP is and why it can be beneficial is important. So for some survivors, injectable PrEP may be the better option because it doesn't require the survivor to keep anything on them, a bottle of pills. However, it could, ultimately have more medical appointments for them. For other survivors, an oral PrEP pill may be a better option, and they might be able to hide it, like I said, in a vitamin bottle. But each survivor understands their own experience best, and this is where really thinking about those risks that are created by the abusive partner versus those that are generated by life factors can influence access to and their continued use of PrEP. And then I know Dr. Ard mentioned PEP and really considering this as well as the tool that we have. So while we're talking about PrEP and prevention, I think considering post-exposure prophylaxis might be something that someone might want or need access to. So if they believe they've been exposed in the last 3 days, providing that as an option, I think is important. Next slide, please. So some possible questions just to start the discussion around PrEP. Has your partner ever forced you to have sex? Do you need any assistance finding resources to support your sexual health care? Have you considered preventative measures around STIs, including HIV? And would you like more information on those? Right, all of these kind of be tweaked depending on your situation, who you're talking with, when you're talking with folks. But there are different kind of specific conversation starters that I've used in the past. Again, these can be tweaked for your own space. So one is like, hey, this has come up with other survivors. So I've just started kind of checking in with everyone. More and more data is showing the connection between abuse and health issues. So some survivors have been exposed to STIs, including HIV. We're also seeing higher rates of strokes and even cancer. So I know that's a lot to process, but have you been able to connect with a doctor recently? Right? Have you had a pap smear or a well woman visit in the past 2 years? I know getting to appointments, may have been difficult, but we do have some really great community partners who can provide support. So you don't have to make any decisions now. I'm happy to provide you with some information if that would be helpful. So another option would be like, it sounds like you didn't have control of your sexual health or reproductive choices. I have lots of information on sexual health that I can provide you, including getting an annual pap smear where you can get STI and HIV testing, how to access HIV preventative care, birth control choices. Would you like any of this information? And if you're interested in any of these services, just let me know. I'm more than happy to provide you with a referral to one of our trusted community partners. So Bringing up sex and sexual health can be challenging if you're not used to it. So tweaking the language to have them really follow your own voice is really important. And I think practicing with colleagues can really help as well. So the more you discuss this, the easier it becomes and the more natural it feels. I think it's also important, especially for like DV advocates who are working with survivors directly in their programming, that these conversations shouldn't happen at intake, right? Entering shelter can be an incredibly stressful time where we're already asking a lot of survivors. So giving them the time to settle, relax, kind of find some balance. And there's more opportunities to have the conversation later. And then just making sure we're providing information in different places so people maybe don't have to ask directly. Maybe they're not ready to ask, but they can grab a brochure or, a card about PrEP. Next slide, please. And then we develop safety plans for a lot of scenarios where harm might occur. However, are we considering harm caused by systems themselves? So medical systems can sometimes be plagued by harmful practices and providers, and domestic violence services um, may have trauma connected to the medical field. So we can help survivors feel comfortable and confident before meeting with medical providers. Even as a medical provider, if you're referring someone to another medical provider, helping them prepare for that. So safety planning isn't just about where am I going, who am I going to see, what do I need to have with me? It's about really including emotional safety as well. So really some things to kind of think about is they're all going to be individualized again, but can you help them create a list of questions ahead of the meeting? Right, these appointments can be intimidating. Help them understand the key terminology. Do they need access to, prior medical information, and how can they get that? Maybe they need a compiled list of medications, ensuring that interpretation is secured if necessary, and sharing what may be their experience around a procedure. If you've ever had an IUD, you know the excruciating pain that comes with it. And sometimes setting people up for that can be very helpful. So talking through those things ahead of time. Next slide, please. Survivors also might have heightened emotions during the appointment, so discussing how they can process those emotions, providing them with necessary tools, maybe breathing techniques, even something as simple as a fidget toy can be calming for someone with anxiety. Can they call an advocate if they're having a difficult time, or do you have a therapist on call that they can speak with? And then there's the know the why. So if a doctor asks, why do you need this? Help them be able to explain how it is beneficial. So an advocate can help them be prepared with facts and talking points to respond to this. So as Dr. Art said, right, PEP is for anyone who asks for it. But that doesn't mean that there still are not doctors out there that are turning folks away because they're not checking specific boxes. So I've worked with a few survivors who have specifically asked their providers, and they've been told, well, you don't qualify because you don't, you're not XYZ. So just having that information is very helpful. And then after the appointment, kind of addressing any concerns that came up. Was there any medical gaslighting that happened? How do we want to address this? Do they need assistance with any follow-up conversations or scheduling appointments? How else can you help them? Just what does the survivor want? Next slide, please. So telemedicine, I covered a lot of this, but again, it just may be the only way for some folks to access medical care. So keeping that in mind as a good option for people. Next slide, please. And then confidentiality, I think, is really important to consider here, especially if programs are working with DV programs, they might be asking for information, and a DV program is not going to be able to disclose that information to them. So it's really paramount to preserving the safety and privacy and trust of those that we're working with in DV programs. So we really want to respect that, and there is reason behind this. for why. So next slide, please. So there is federal legislation that really prohibits the sharing of personally identifying information with anyone outside of programming. Programs are really prohibited from requiring survivors to sign any release of information. So PII, or personally identifying information, is the information that is likely to disclose the identity location of someone. So this could be a first and last name, an address, phone number, IP address, even social security number, driver's license number, and even any other information that could serve to identify an individual. So it could be date of birth, racial or ethnic background, number of children, any information about children, place of employment. So depending on your community, that can look very different. Next slide, please. So very briefly, just asking for medical information, keep the questions very general and make sure they're optional. And if you have vetted physicians in your community that you know are trauma informed, providing a list of trusted medical providers in your community. So if they need to see a doctor for something specific, and maybe that you're not ready for a referral, they know where they can turn. Next slide, please. And then documenting medical information, really documenting only what is absolutely necessary to provide a service at your organization. Not to just access services at another organization. Remember that what is written down can be a liability in some spaces. It could be court ordered at any time. And if someone wants to document medical information, just making sure it is in something that is end-to-end encrypted if they're going to go the tech route. So no one else will be able to access that information. Next slide, please. And there are plenty of opportunities for collaboration, right? Cross-learning opportunities, shared decision-making that comes with great community collaboration, and an opportunity to take risks together. Next slide, please. So some of this can look like co-presenting to staff and clients and community members, conducting site visits to each other's organizations to get a better idea of how each other work, and sharing materials with each other. Next slide, please. Co-running community testing organizations, identifying some shared resources to help folks access different services. If your community has a coordinated community response team, and ensuring that HIV organization can participate in that, and possibly even having an on-site DV advocate at the HIV organization or your health center is a possibility as well. So there's plenty of opportunities for great partnerships to happen in communities. Next slide, please. So these are just a few resources I threw together for folks to access if you're interested in more information about confidentiality or where to access PrEP. And next slide, please. And I'm going to turn it back over to, I think, Futures.
Excellent. Thank you so much, Ashley. That was so informative and helpful. And thank you so much to Dr. Ard. And I'm going to ask that we actually bring Dr. Ard back on camera because we do have a couple questions for both of our speakers today. We don't have tons of time, but I think we can squeeze in a little bit. The first kind of group of questions, I'll go back to you, Dr. Ard, are just around PrEP and just kind of some more of the medical questions around that I'll just kind of give to you all at once because I think they're all kind of related. One is about, can any provider talk with patients about PrEP and prescribe, or does it really have to be an HIV provider, sexual health provider? Could a family medicine provider address this conversation and prescribe? Then another question around age and prescribing PrEP, age of the patient. And then lastly, can any of the injectable PrEP options be self-administered yet? So we'll start with you.
Great. So any provider who can prescribe medication can counsel about and prescribe PrEP. You don't have to be an HIV specialist or a sexual health clinician. So primary care clinicians, family medicine, OBGYN can all provide PrEP and all do around the country. There are actually also even some examples around the country of pharmacist provided PrEP, which is great because many pharmacies are open on the weekends and open in the evenings which might be more convenient for patients. In terms of the age-related question, all of the agents that are approved for PrEP are approved for PrEP in adolescents as well. They do have some weight restrictions. I believe it's 35 kilograms for most of the drugs. Now, that being said, there may be some issues you would need to navigate around parental or guardian consent if you were providing PrEP to an adolescent, and that often is impacted by where you are practicing. So, for example, in the state where I practice medicine, we have a mature minor doctrine, and so we could consider a person to have the capacity to consent to PrEP on their own without involving a parent or a guardian, but that may be kind of jurisdiction specific. And then about self-administration. So unfortunately, self-administration is not recommended for any of the injectable options right now. Maybe that will change in the future. Cabotegravir is an intramuscular shot given in the buttock, which may be challenging to give to oneself. And lenacapavir is actually a pretty large volume that has to be given subcutaneously. And I think many clinicians find that one harder to give than the intramuscular injection. So I think it would be somewhat difficult to give oneself. And if it's actually not done properly, there's a risk that people can develop an ulcer at the site of the injection. So for now, that one should also be given by a healthcare professional. Maybe we'll have in the future options that people can give themselves, or we'll sort out how people can safely give the current options to themselves. But right now, that's not a good option for self-administration.
Thanks so much, Dr. Ard. That's
Sure.
super helpful. And then we had one for you, Ashley. Just coming back here. I think my DV program could use a training around HIV and PrEP. How could we get more information on how to do that? Would a local HIV program partner with us to do that?
Yeah, thanks, Kate. NNEDV would be more than happy to support. We do trainings across the country, both in person and virtual. And these can be co-trainings between DV organizations and HIV organizations and other healthcare providers. So we work very closely with organizations to make sure that the training is individualized and is really meeting the needs of the community. So please feel free to reach out to us at dvhiv@nnedv.org, and I'd be more than happy to chat and see how we can support you.
That's great. Thanks so much, Ashley. And I think so important. You were talking a lot about partnerships, and I think, domestic and sexual violence, human trafficking programs can offer an HIV program or any community health center, just a lot of information on safety planning, supporting survivors. But likewise, a community health center or HIV program could come back and, share information and strategies with the domestic and sexual violence program around stigma around HIV and reducing stigma. Because I think when we think about barriers to getting tested, barriers to engaging in HIV care, it's kind of just another layer of stigma on top of the stigma of experiencing domestic and sexual violence. So I think, for whomever asked that question, definitely reach out to Ashley at NNEDV. I think that's all of the questions we have time for today. I saw Ashley just dropped her email in the chat, so please reach out to her, folks. And we'll just end with a couple slides. If my slide sharers could bring those back up. Seeing some thanks in the chat for our ASL and Spanish interpreters. Indeed, yes, thank to them. All right. So just ending with kind of some bread and butter information here. I think we really just want to underscore the importance of domestic and sexual violence programs and community health centers partnering together. And it is really that partnership that supports the work of healthcare folks working in health and health centers, being able to better support survivors, engage in domestic and sexual violence, human trafficking prevention work. And then, like I said, really be able to help those working in domestic and sexual violence organizations be able to really support the health and well-being of survivors. And you'll see on your screen here just a little graphic. We'll make sure to email all of this information to you all. So yeah, really just hope one of the takeaways for today for all of you is just the importance of partnership, which I think we saw a beautiful representation of today with our speakers. Also wanted to share a safety card that we, Futures Without Violence, have developed in partnership with organizers who organize around safety and well-being for people living with HIV, called Health, Healing, and Relationships. It talks about the intersections of HIV and partner violence and has supportive resources on the back of this card. So you can order these cards at a link that will be emailed to you, or if someone has capacity to drop that link in the chat, that's great too. And just want to end today. I know we're right at the top of the hour. Just thanking everyone so much for joining. And also please fill out the evaluation if you would like to get a certificate for continuing education. Definitely fill out that evaluation. And thank you so much to our amazing speakers and our excellent interpreting folks and partners. And thanks so much for joining today, everyone.